Bore da, gyfeillion, croeso I gyfarfod bwrdd iechyd Prifysgol Cwm Taf Morgannwg. Good morning, colleagues, and a very warm welcome to this meeting of Cwm Taf Morgannwg University Health Board. We are streaming live today due to the continuing restrictions in respect of public gatherings and essential travel, and we hope that this will give the opportunity for anyone with internet access to observe in real time using a link that was shared via various channels prior to the meeting. I would like therefore to extend a warm welcome to all those who may be observing the meeting today. Can I just advise you that we may not always be looking at the camera, as we're also referring to our board papers throughout the meeting. So thank you very much, colleagues. As you will be aware, we're implementing a process whereby questions are sought in advance of the meeting, which are then addressed by the relevant officer lead. So I do not intend to read them out during the meeting, as they have all been shared prior to today and have been included for ease of reference under each agenda item within our board book system, and also shared separately with those not on the system. The questions and answers will be formally noted in the minutes. Warm welcome to colleagues joining us for particular items on the agenda today. So to Debbie Benyon, who is our Deputy Executive Nurse Director, and Val Wilson is the Director of Midwifery, Gynecology and Sexual Health, who are in attendance today in the absence of Greg Dix, our Associate Nurse Director. Before we get on to the agenda, there are just a few very important announcements I wanted to make, if you will let me. First of all, Dr. Sharon Hopkins, our Interim Chief Executive, will be leaving the board next month. So this will be, I think, Sharon's last board meeting. So on behalf of the board, Sharon, can I extend our thanks to you for your huge commitment, your dedication, your passion and leadership over the last 12 months or so. You've made a huge difference to this health board, and you will be sorely missed when you leave. Can I then, following the recent process undertaken to recruit a substantive chief exec, I'm delighted to confirm that Mr. Paul Mears has been appointed as the new chief exec for the health board, and he will start on the 14th of September. I'm also delighted to confirm that the Minister for Health and Social Services has agreed to extend Maria Thomas's appointment as Vice Chair of the Health Board for 12 months until September 2021. And then finally, under these notifications, I have recently received notification from Paul Griffiths that he has tendered his resignation to the Minister for Health and Social Services, noting that he will be stepping down from his role as independent member for the Health Board, just short of his 4-year term. Paul has made a huge contribution, as we all know, in many areas in relation particularly to finance and audit, but generally to the work of the Health Board. But we'll have an opportunity, I think, to thank and to embarrass Paul before he leaves at the end of this year. So item 1.3, apologies for absence. I've received apologies from the following: Dilys Juvenat, independent member; Ian Wells, independent member; Jim Hare, independent member; Greg Dix, executive nurse director; Georgina Gillette-Lee, the director of corporate governance; and Liz Wilkinson, executive director of therapies and health sciences. And also from Olive Francis, the vice chair of our community health council; Gio Isingrini, who's an associate member, as are Sharon Richards and Suzanne Scott Thomas, who both also send their apologies. Thank you very much. Can I, colleagues, item 1.4, declarations of interest. I've not been notified of any, but I'll just pause briefly now in case anybody has any declarations that they need to declare in relation to today's agenda. No, good, thank you very much. Item 2 then. So to ensure that we focus on business critical activity and discussions at this time of crisis, the COVID pandemic, we are using, as you know, the consent agenda for this and other meetings. I'm assuming that everyone has read all the papers under the consent section. Are there any issues, colleagues, that anyone wishes to move from the consent agenda to the main agenda to ensure detailed discussion today? Again, I'll pause to give people a chance to raise anything if they wish. No, good. So I propose therefore that we are all content to approve and note as required the items under the consent agenda, which is essentially part 2, number 2 on our agenda today. Good. Let's move on then to the main agenda, where we need to have more detailed consideration and discussion on more complicated matters. I'm going to propose a slight change to the order today, if I may, and to move item 3.3.3, which is the Maternity Services Improvement Programme, and take that as our next item on the agenda, so that the staff who are here today for that item are then released to go about their normal work. So Val, can I hand over to you? Val Wilson is our Director of Midwifery, Gynecology and Sexual Health, to present the report, please.
Thank you, Chair, and thank you for bringing the item forward. So a brief update on the last month or so's work within the programme, and a more general update on maternity services itself. So as you'll be aware, we are currently standing at 41 closed recommendations and are proposing a further 17 to the IMSOP panel, at our formal panel in August. 15 of those being recommended for closure, 15 demonstrating further, demonstrating further improvements in some recommendations. We have focused, whilst continuing to be in our COVID, under COVID restrictions and working within our COVID pathways, we've done some quite targeted pieces of work around serious incident management, around complaints in terms of both quality and addressing the backlogs. A very large piece of work in relation to our guidelines, reviewing, bringing them up to high standards, including the multidisciplinary team. We have also undertaken a large piece of work working with our neonatal colleagues to address the backlog in relation to perinatal morbidity and mortality reporting, and we've aligned very closely now to the national PRNT process, having addressed the backlog for 2018-19, and are now moving more into a business as normal, reviewing cases as they come along. During the last 6 weeks, month, we've undertaken a large-scale review of the IMSOP improvement plan, and the purpose of that is to move us from a place where we are responding to the RCO recommendations, although we will continue to respond to those recommendations as individual recommendations, but moving us into a place where continual improvement becomes part of our business as usual within the service. So we will be aligning our maternity improvement plan into our assurance framework that's being developed for the service. We're getting very strong engagement from all parts of the multidisciplinary team to take that forward. During this period, we've undertaken a large piece of work to review our evidence, the focus having previously been on the PCH site, the Merthyr site, to ensure that we've also been inclusive of our site at the Princess of Wales Hospital, and I'm pleased to be able to report that actually the evidence we have previously reported was inclusive, and certainly since I've been in post, we have moved forward as one service, standardising both our clinical pathways and the processes around governance and assurance, so that work will continue. In terms of the external review, we have now completed all of the pre-review work in terms of maternal morbidity, stillbirth, and are in line with the neonatal work. So those are now progressing at approximately 6 per week to be uploaded to the external reviewers. On the other side of that process, we are now receiving some of the initial feedback from the review teams, and are working very closely with our corporate colleagues, both legal and claims and redress, to look at how we respond to those before letters go out to families. So an awful lot of work going on around that to ensure that we're able to engage with our families in a very sensitive and robust way going forward. In terms of any slippage that we have had some slippage in a number of areas, and this is all related to the restrictions that we've been placed in during COVID. So, for instance, our leadership programme was stood down in March, and we are now working with the external company to look at innovative ways of taking that forward. There was also some slippage in terms of how we were going to continue to engage with our families. And whilst we've had some slippage in terms of the planned work, what's really evident and very encouraging is that we've continued to use some of the methodology we'd identified previously to get some really very exciting engagement with our users during this period, and we've had exceptional feedback during that period. So we're now building that into a much bigger plan, so we have a forward plan for how we will continue that engagement, not just in the here and now, but as we look to develop our services going forward. It's fair to say that there's also been slippage around job planning as an organisation. That was stood down, and again we're now looking at how we're going to pick that up. And that is also true of our multidisciplinary training. We've continued to do training in a limited format during this period, but we're now aligning ourselves to the Prompt Always approach and are part of that work stream to pick up that training. I'll respond, if I may, to some of the questions that have come in. One question related to slippage, which I think I've answered, was in relation to some of our engagement work. And whilst we've actually closed the recommendation related to, we're actually opening up these work streams again as we develop our maternity improvement programme that will sit within the service. Another question in relation to the increase in caesarean section rate at the Prince Charles site. So I did a 6-month review, which tells us that whilst there has been a slight increase in the last 2 months, actually overall the rate is quite steady at 30.1% for the last 6 months. We compared that to 2019, and for the same period our caesarean section rate was 35.8%. So I think that's an encouraging reduction in the rate, but we must be careful not to look for a low rate. What we're looking around is very strong decision making around caesarean sections rather than a reduction per se, but good to see there has been some reduction and that we're getting a sustained rate now. How that compares to the rest of Wales is we're about 2% higher than the rest of Wales, and the work we're looking at now is to understand why that may be, and there are some clear indicators already, although we're at early stages, around our very high rates of deprivation, our high rates of BMI, which we absolutely know does have an impact on caesarean section rate. So our caesarean section working group is now back up and running, and we're getting some support from Improvement Cymru to help us look at that in a very robust way.
Val, thank you very much. That's a very helpful paper that you've provided for us, and thank you for addressing those specific questions and providing a bit more detail. It's very helpful. Sharon, did you want to come in?
Thank you very much, Marcus. Yes, just a couple of things. Again, thank Val and the team for all the work that's happening across all of the teams. I think we can't under-emphasise how much work continues to go on, and the fact that the work has to absolutely be continuous. And the teams have been really hard at this for now more than a year, and we know that there is a lot more still to come. And when we talk about continuous improvement, that's exactly what the teams are displaying. And in a sense, the business is never done, because improvement will continue no matter how good we get. And I can see Val smiling, and she knows that that's what this is all about. So working with ladies, families, our staff to secure that focus on continual improvement and that resilience and energy is really important, and I think the teams have done really well to keep on that real positive continuous journey, continuous improvement journey. I'd just like to remind the board that we will have a further report from the independent panel in the next towards the end of September, So again, that'll be another independent view on the improvements and progress that's been made by our teams. And also very pleased to say and to remind you that the Tyrion Birthing Centre is due to reopen on the 5th of October. And again, colleagues will know that the birthing centre was very well received by ladies and their families. We had to take it down over the COVID period, but now, thank goodness, we're able to get that back up and running, all things being equal, in October the 5th. So just my thanks to the team for their continued focus on quality, on their patients, ladies and the families, and on continuous improvement. And just again emphasising this bit about keeping your energy going for continuous improvement can't be under-emphasised, because it means that the job is just never done. So you can't step back and take a breather. The teams are continually on the case. So Val, teams, thank you very much.
Sharon, thank you very much. We've got some questions coming from colleagues. Colleagues, just to remind you, I'm using the dialogue function to know who wishes to come in. Nicola, I think you're first.
Thank you, Chair. Thank you very much, Val. I think we're all aware of the tremendous amount of work, Val, that's gone on in maternity and the improvements that have been made. I just wanted to ask, I think it's with sadness I read in your report that the culture is still seen as punitive within maternity, but I have noted that there is a questionnaire going out. I just wonder, Val, is there a deadline for completion of the questionnaire? And then do you have an idea when you will have the data so that we can have a look at what staff need and how we need to take it forward for further improvement, please?
So yes, Nicola, thank you. We actually undertook a questionnaire around, we wanted to understand that there was still a feeling around when we investigate incidents, and that staff were still very worried about being involved in investigations. So the piece of work that we wanted to undertake was to look at, is that still the feeling? Because an awful lot of work has been undertaken, and if it is, what could we do differently? So that questionnaire has now closed. We've had 130 responses, which is wonderful, and we're just going through the analysis now, and we'll be able to report on that in the August reporting cycle.
That's great. Thank you very much, Val. Thank you, Chair.
Thanks, Nicola. 130 responses, that's a very encouraging figure. Maria, come to you next.
Yes, thank you, Chair. Thank you, Val, for that concise report. Can I just remind members of the board that the scrutiny that is undertaken via the Maternity Improvement Board is quite significant into the improvement work and into some of the RCOG recommendations and taking those forward. And Val has very eloquently in the mid-meetings and following the mid-meetings and with questions that had been put forward from independent board members, come back with very precise answers to those questions. So it's just a reminder really that you know there is quite a lot of scrutiny that goes on in the Maternity Improvement Board, and that assurance is given and taken up via the Quality and Safety Committee and through to the IMSOP.
Thanks very much, Maria. Colleagues, nobody else has indicated that they have a point to raise. So can I just, Val, can I thank you for everything that you and the team are doing and your leadership to this. I think there are lots of encouraging signs that you've reported to us in the paper and just now orally, and still a long way, as we know, a long way still to go to make absolutely sure that the changes are made and that they, even more important, that they're embedded. I think the work that's been going on with families engagement has been particularly impressive amongst the range of issues, and for me that's one of those issues for the future that can give us some assurance that improvement continues. Involving families in this is a crucial element, isn't it? And also good news, as Sharon says, that the Tyrion Birthing Centre and all of the support that it provides, it's so much more than just a physical building. It's a whole wealth of support for people. It's great that that's coming back on stream shortly. So Val, thank you very much indeed, and we'll let you get back to doing the work. Thank you very much indeed.
Thank you.
Right, colleagues, we go back to the agenda in the order that it's set out. Item 3.1 is matters arising not considered within the action log that we've taken in the consent agenda. I'm not aware of anything that isn't included, but now's your chance just to raise anything if you wish to. No, good. Then let's move on to item 3.2, 3.2.1, which is the COVID-19 update. And again, Kelechi, another note of thanks to you and the team for the huge work which you've been doing over the last months and continue to do, because as we all know, COVID-19 certainly hasn't gone away yet. So, Kelechi, we've had your paper. Thank you very much. Anything you particularly wish to draw to our attention?
Thank you very much, Chair. Thank you. Good morning, everyone. The report in there has a lot of the detail, again, a lot of which will be very familiar to members of the board. The key elements of the updates is essentially the emphasis on the Test, Trace and Protect program, and giving the board assurance and confidence that that program is running exactly according to plan. Granted that we have had significant changes in the system, some of which I'll make reference to, but I'll just do a very quick reminder of to the board on the key elements of this program and how crucial they are to our readiness for whatever the winter is going to throw at us. Surveillance has been one of the key elements of the Test, Trace and Protect program, and just a reminder of the 4 key objectives of surveillance and how important it is to us. We're keeping a very, very close eye on indicators that are helping us to monitor the intensity and severity of COVID-19, even as we are in a relatively quiet period. Making sure that those systems are in place is a matter of strategic importance to us, because when we get into a busier winter, as we suspect we might be, we will need to make sure that all those systems are in place. Understanding the behavior of this virus in at-risk groups. So what is it doing in healthcare settings? What is it doing in care homes? Looking at immunity. So now we're beginning to get more antibody data. And just as an update, because it's not in the paper, I'll just mention that in CTM, we've done more than 8,000 antibody tests across healthcare workers and across education and teaching staff. And we're beginning to get the results of those antibody tests. And it's already, whilst at this point, no one is making any assumptions about whether the presence of antibodies guarantees immunity. There is no evidence as yet to tell us that that is the case. But at this point, we are beginning to understand how CTM is doing in terms of seropositivity compared to the rest of Wales. And as we might have expected, our levels of seropositivity are slightly higher than the Welsh average, which simply reflects the fact that we have had more cumulative cases than the Welsh average over the period of time that we have faced this pandemic. The testing work stream is going very well. We've created significant headroom in terms of our testing capacity. Not all of that headroom obviously is being used, but that's not worrying, because actually we need that headroom going into what is likely to be a busier period over the next period of weeks. Contact tracing again is going very well, and we're now beginning to get data from the case management system that tells us, I mean, you may know about the 80-80 rule. So 80% of contacts, 80% of cases traced and 80% of contacts followed up. And we are currently doing about 82% and 96%. So well over the 80% basic, and we continue to make improvements. There are variations from one local authority to the other. Some local authorities have higher rates than the others, but generally, we are doing very well in terms of exceeding that 80% follow-up of cases, 80% follow-up of contacts. As far as risk communication is concerned, we already made reference to the survey that we did in our community, completed by 7,000 people in our community. And that survey is going to be important for us to understand attitudes to COVID vaccine, for example, in our population, because as you know, the Welsh government has expressed some degree of confidence that we may actually have a vaccine available before the end of this year. And if not before the end of this year, perhaps early next year, we should have a vaccine available. But we have been asked to ramp up our preparations for COVID vaccination, and we're doing a lot of work on that. At some point, I'll be bringing back a more detailed report to the board on our preparation for COVID vaccination and preparation for seasonal flu as well. The other information there that and then I'll stop is resourcing. So obviously, you know, that we have received £5.4 million from the Welsh government to support contact tracing via the local authorities. But we've also made a representation to the Welsh government to put out very similar support for other elements of the Test, Trace and Protect program, because they are as important as the contact tracing program, which cannot work in isolation of testing or surveillance or risk communication. So we continue that engagement and continue to refine the financial and workforce requirements and calibrating them to the demands that we're getting in the system. So the report is there for the board, and I requested for the board to note the good progress we've made in relation to developing and implementing the CTM Test, Trace and Protect program. The assumptions we're making on scenario planning, and just looking at what the winter they're having or have had in the southern hemisphere looks like, and if we get anything close to the kind of winter they are having or seasonal flu circulation they are having, we may just be in a good position. But I think everyone understands that it's very difficult to predict the kind of winter we may get. So we're preparing for the worst and hoping for the best as far as that is concerned. And then finally, to note the latest estimated summary of the program cost. And as I said earlier, we continue to engage with the Welsh government in terms of ensuring that we have proper funding for all of the elements of the Test, Trace and Protect program, and not just for contact tracing. I'll stop there, Chair, and take any comments or questions.
Kelechi, thank you very much. And we've had a number of questions from board members, I think, in the run-up to today's meeting, which you've answered very, very comprehensively in the papers. Thank you very much. And thank you for the paper. Colleagues, anything anybody particularly wants to raise? Sharon.
Thank you, Chair. Kelechi, thank you for that paper and all of the work that's going on with all of the teams. I just can't resist the opportunity to just remind people of the huge importance of maintaining social distancing and hand hygiene. And as some of the rules and the advice changes, just asking people to continue to work with all of those processes. Social distancing and hand hygiene is the one thing that really will keep us in good stead going forward, because as Kelechi says, we really don't know what we've got ahead of us, and COVID is certainly not a done deal. So I just wanted to emphasise that while we've got the opportunity, and ask board members that when they're out and about to act as advocates for continuing with those messages. Thank you.
Thanks, Sharon. Very timely. Mel, I'll come to you next, please.
Yes, thank you, Chair. Kelechi, thank you very much for all the brilliant work that's been going on. Really, you know, should have great credit for you and the team, what you've been doing. I'm speaking now as if I was a member of the community listening today, and you mentioned the possibility of a vaccine becoming available, possibly before the end of the year or possibly early on in the next year. And I'm sure community members, especially the more vulnerable community members, will be thinking and hoping that when a vaccine becomes available, that there could also be an accessibility plan, so there will be a prioritization as who might receive that vaccine before some others. I'm presuming that's correct. Is that right?
That is correct, Mel. So far we are doing a lot of work that I haven't got into detail here. We're doing a lot of work on setting out our plans as a region, CTM region, for COVID vaccination under a very clear framework from the Welsh government. So a lot of work is going on, and we are going to exercise some of those plans and get them ready. Now, the current thinking, I don't think this has been formalized, but the current thinking, and it completely makes a lot of sense, is that it will be prioritized initially, and the prioritization will probably focus on some of our experience in the first wave, if you like, where we had quite a lot of activity amongst healthcare workers and social care workers. Inevitably, those will be prioritized, as well as vulnerable groups. And the definition of vulnerable groups at this point is more likely to follow the definition of shielding and vulnerable groups as per the first wave. So that's the current thinking, but that I believe will be formalized as we go into the next couple of weeks.
Thank you, Kelechi, and well done once again. Thank you, Chair.
Thanks very much, Mel. Jane Sadgrove, will come to you next, Jane.
Thank you, Chair. And thank you, Kelechi, for a very informative paper, which really sets out the extensive work that you and the team have been doing to try and keep our population safe. I am interested in the points you make about the Southern Hemisphere, and clearly there's difficult news coming out of Victoria and Australia today in relation to the spike that they're having there. But I wanted really to pick up really that Sharon brought into the conversation, which is the need for us and our communities actually to continue to observe social distancing, face coverings, hand washing. But I'm getting the feeling there's a bit of lockdown fatigue creeping in. How do we actually motivate our communities to continue with these measures to protect themselves and to protect others? How are we actually approaching that?
So you are absolutely right. What's going on in the Southern Hemisphere is a bit of there's a mixed picture in there, because the seasonal flu activity is very low, whereas some places in that hemisphere, like Victoria, as you said, are beginning to experience a real spike in COVID cases. And there is a complexity in there, because the thinking is that seasonal flu is low because of the success of some of the preventative initiatives related to COVID, such as social distancing. And so it is interesting that we're beginning to see that sort of picture. But I think what it does tell us is that our Test, Trace and Protect program is crucial, because this program was framed to get us ready for a second wave, or a resurgence, as the WHO would like to say, rather than a second wave. And so our focusing on that Test, Trace and Protect program and making sure we get it right, I can't emphasize enough how crucial it is. And a key element of that Test, Trace and Protect program is the risk communication and community engagement element. Now, that is the element that allows us to, or through which we're interacting with members of our communities, understanding what's going on in their minds, if you see what I mean. So what are the current attitudes to vaccination? What are people thinking about the COVID vaccine? What are people thinking about lockdown? To what extent are we actually getting lockdown fatigue? So we think anecdotally there is some degree of lockdown fatigue, but actually there's something about going beneath and really understanding the nature of that lockdown fatigue. When cases begin to spike, as you may have picked up in the news in Oldham, cases are spiking and people are wondering, other people are saying, well, actually, if we did more of social distancing, we shouldn't be here. So actually, might it be that a spike in cases then changes people's attitudes again and increases awareness around social distancing? So I think you are right to highlight that, Jane. Our risk communication and community engagement work stream is crucial, because that's the only way we understand what's going on in our communities, and then being able to adapt our interventions and engagements accordingly. But I do think, as Sharon said, every opportunity we have to press home the message of social distancing, universal precautions, wearing of face coverings where you cannot achieve social distancing, I think is really crucial. We take every opportunity to do that, because that's, in addition with a very competent Test, Trace and Protect program, is our only route out of a potentially crushing second wave, if it does happen in that way.
Thank you, that's really reassuring, and keep up the good work, Kelechi. Thank you.
Thank you, Jane.
Great, thank you very much, Kelechi. That's very helpful, very informative update, and thank you for the paper. Colleagues, we'll move on then. We're asked to note the paper, which we do. We move on then to a closely related issue, actually, item 3.2.2, which is managing the risk, particularly to our Black, Asian and minority ethnic communities in relation to COVID-19. We as a health board have on several occasions already acknowledged the massive contribution which the hundreds and hundreds of staff in our organisation who come from those communities continues to make, and our debt of gratitude to them, and a recognition of the particular vulnerability which they find themselves in because of what is emerging in terms of our understanding of the disease. Howell, you've written a very helpful paper for us, again updating, which colleagues have had a chance to ask questions and which you've responded to. Is there anything particular today that you wish to draw to our attention, Howell?
Thank you, Marcus. Just two things really to mention. So on this particular issue, obviously the risk assessment process has formed a key part of our actions in respect of the issues you just mentioned, and indeed mitigation of those issues. So and a lot of the questions from independent members that came through before the board meeting have related to that process. So just to comment on that, we are now working very, very closely with ILG directors and senior teams to ensure that we complete the risk assessment process for all of our BAME colleagues. And then obviously there's another key piece of our work there, which is the introduction very recently of our BAME staff network, which is a new development which has taken place during the course of the last couple of months. Which we hope then will inform our future work in this area, as well as our more broad work around inclusion and diversity for the health board. But those are the 2 points I specifically wanted to mention, really, and we hope to have completed all of the risk assessments by the end of August. There is some reluctance among some groups, which I've alluded to, and again, members have asked questions in relation to. So again, we're working with individuals to resolve some of those individual issues.
Good. Thank you very much, Hal. That's very helpful and clearly a very important issue for us all. So, colleagues, we're asked to note the update, which we are very happy to do. Again, Hal, to you and the team, thank you. I'll move on then to item 3.2.3, the values and behaviours framework. Another crucial piece of work for this health board lies really at the heart of our move to tackle some of the issues that are a particular challenge to us, and all of the work that's going on in this area, I think, and we all think, is absolutely fundamental to making progress. So, Hal, a really important paper that you've done for us. Anything particular that you wish to draw to our attention?
Thank you, Marcus. If you don't mind, I just wouldn't mind reminding independent members and board members of the background to this a little. So this is a hugely important piece of work for us as a health board, as we've alluded to. What we're really trying to do with this piece of work, and what we mean when we talk about values and behaviours, is a clear articulation of what's important to us as an organisation to guide our business. And to guide the kind of culture that we wish to engender through describing what's important to us, to influence how we make decisions, and then how we behave and interact with each other, so crucially with our patients and our communities. Just to remind members then of the process that we went through to develop our draft values and behaviours pre-COVID, and then some of the work that we've done then post-COVID to refresh in light of the experiences that we've had over the last 3 or 4 months. So you'll remember that we engaged an organisation externally to help us with this work. As part of their pre-work to undertaking the work, they did a lot of research in this area, both in terms of academic research, but also contextual research for us as an organisation, which included looking at the Welsh Audit Office report into the Health Board's quality governance arrangements, the maternity report that we received from the Royal College of Obstetricians and Gynecologists and Royal College of Midwives, and indeed the detailed feedback that we received from Women and Families as part of the RCOG RCM report, which contained hugely rich information in terms of feedback we'd received from our communities. In addition to that, then, once that research had taken place, we ran a number of sessions across the autumn and winter last year, which included around about 500 of our people internally and around about 150 of our members of the public, including CHC members, and I'll come on to talk about the CHC involvement in the work in a moment. As well as that, we ran a survey which we had approximately 4,500 responses to, and members will recall that our previous responses to surveys in the staff survey in the previous year had been around about the 1,200 mark, so a hugely improved response to the survey in relation to the values and behaviours. Once we'd done all of that work prior to COVID, around about March time, then we ended up with a draft set of values and behaviours to take to the organisation to reflect. And then the work halted temporarily while we were going through the first wave of COVID activity. In May, as we began to emerge from the first wave, we decided that it was opportune to go back to the organisation and reflect whether what we'd learned had changed things at all, and whether the draft values and behaviours we had developed still felt relevant and resonated with our people. So we undertook a short survey where we took feedback on that, and also took the opportunity to check in on the well-being of our staff and get some data in relation to that to inform our well-being activities. We received approximately 1,500 responses to that in a week, which again we were quite pleased with as a response to the survey, and again we received some very good feedback in relation to the resonance of the draft values, which influenced actually the final draft. Following that survey, we then ran two specific workshops. One firstly with the project team who'd been overseeing this work for a significant period for us, and the ILG senior teams to make sure that the work was connected into ILGs. A really engaging, well-attended workshop, which just gives you an indication as to how important people feel this piece of work is, and we received some really good feedback. And then secondly, a workshop with executives, independent members and trade unions to take some further feedback, which again was very well attended. Once we'd been through those, we then took the draft set, a final draft, if you like, values and behaviours through the organisation's governance procedures, including the executive team, management board, people and culture committee on Monday, and now the board today. And as part of that process, had a discussion with the CHC. Now I was going to bring Cathy Moss in at this point to comment on the CHC's involvement, but Cathy's having some technical difficulties and is only able to observe. I've checked with Cathy, she's happy for me to put forward her views on her behalf, which I had from her on email, and she's confirmed that she is. And Cathy has confirmed that CHC members had the opportunity to contribute to the work as we undertook the sessions back last year, and the final draft has been shared with CHC members over the last week or so, recognising the involvement that took place as part of the process. I guess that the only thing to say is that what we're asking then the board to do is to approve these set of behaviours and values for us. And the next piece of work then, of course, will be to work to embed these values and really bring them to life for the multiple audiences that they talk to, which include obviously our 12,000 people across the entirety of our patch, and weave those into all of our people processes and organisational decision-making processes, but then obviously crucially our communities and our patients. And working to translate those into what our staff can expect, what our patients and our communities can expect from us when they interact with us as a health board. And that was all I wanted to say. Thanks, Marcus.
Howell, thank you very much. That's very helpful. Jane, can I come to you first? You're as the chair of the People and Culture Committee. Very important discussion you had on Monday. Thank you.
Indeed. Thank you, Chair. And thank you, Howell, for that presentation, which I think really enhances the information that's in the paper and brings it to life. I mean, there's been enormous engagement over development of the values, and I think that they are really starting to live. Earlier in the meeting, we heard from Val in relation to the maternity improvement work and the level of response that they're getting there from staff. And I think that's, you know, actually part of seeing the values come to life and the trust that we're building with staff. So it's really good to see. We did have a good discussion at the first meeting of the new People and Culture Committee on Monday. And I know we gave you a few challenges around, okay, so what are we going to do with these? And I know you've met since then with Cwm Montague, who unfortunately couldn't get into the meeting today for technical reasons. And I can confirm that Kieran is very keen that we support these values and behaviours today. So what the People and Culture Committee is really interested in is, yes, we'll approve these today. What are we going to do with them? What's the implementation plan? How are we going to take these forward? And we recognise, of course, that these aren't static things. They will evolve and develop, but it's really important we take now this first step and endorse them so that we can get on with those next stages. So I think it's more of a comment than a question, but very happy to say that the committee is supportive of these values as set out.
Jane, thank you very much. Sharon, can I bring you in?
Yes, thank you very much, Marcus. And again, Hal, thanks to you and the team for all the work that's been done on these. I think Jane has already said that how very important these are to the direction in which the organisation is going in, and one of the fundamental actions that are required of the organisation when we go back a year and look at some of the reports that were somewhat critical of us as an organisation. I think the work that's been undertaken with respect to engagement and involvement has been really very, very good, as ever, because we are, I think, genuinely becoming a continuously improving and learning organisation. We will always recognise that things could be done even better. We've always very clearly said, and I think are starting to live this, that what we start with and what we finish with are unlikely to look the same, because if they did, we wouldn't be learning and improving as we work with things and as we develop things. And the only other thing I want to say was which is a little bit of a challenge to the board, but the board has to own these. So it's not just a matter of supporting and approving. The board itself has to absolutely own these values and behaviours, so they are ours collectively. And the work that we do as a board to enable them to embed and become alive is our work that we've got to do. It's not about Howell and the team. Now, I know that's well understood by the board, but again, on my last board meeting, I can't resist being a little bit challenging to all of my colleagues. So the ownership of these is what I think the board really has to take on, and then how we're going to demonstrate that ownership as we work forward into the coming months. Thank you, Chair.
Sharon, thanks very much. That's again also very helpful. So, colleagues, can I just note that Kieran has been communicating with us off screen because unfortunately he's got a technical issue about coming in, but he is, as Jane has said, very happy to support these. I think the very creation of a new committee around people and culture, one of only a relatively small number of committees that we have as a health board, is testament to how important this issue is. Absolutely vital that in all the pressure of all the other events that we have to deal with as a health board, responding to COVID and everything else, that we don't neglect and that we don't fall into the trap of giving insufficient importance and priority to such a fundamental change. And the test, of course, as everybody has said, will be, is this embedded actually in the organisation? And I think certainly from the board's own perspective, we need to give some thought now to how at each meeting we reflect upon the impact that the values and behaviours are having, and whether we are, as Sharon says, ourselves embodying them too. There are some important challenges as we go forward in terms of ensuring that the community's feedback and patients' feedback continues to inform this as it develops and is embedded. And we also need to look in particular at how we ensure that all aspects of health service provision are informed by the same values and behaviours. But colleagues, again, thank you for this important work, and we watch with very eager anticipation as it's rolled out and properly embedded throughout the organisation. So we're asked to approve the values and behaviours statements. We're asked to approve the process outlined in the paper for beginning to embed those across the organisation, and to note the approach taken to date and the steps for their launch. Colleagues, I will just pause very briefly to see if anybody has any objection to us doing those two approvals. No, good. Thank you, Hal. That's very helpful. Let's move on then. Item 3.3 is well, there are several items here to do with aspects of quality and safety, and the first one that we take is 3.3.1, which is about safe, sustainable and accessible emergency medicine and minor injuries and illnesses services, particularly for the people of Rhondda Taf Ely. And I hand over, Nick, to you.
Thank you, Chair. I'm sure the board needs no reminder of the commitment last month for a 24/7 consultant-led emergency medicine service at the Royal Glamorgan Hospital. The paper in front of us today lays out how we continue to ensure ongoing high quality, safe, sustainable and accessible emergency medicine, minor injury and illness service in the Rhondda Taf Ely locality. And of course, we've got to do that in the context of COVID and all the challenges that brings. And as I constantly need to remind myself, in the context of the agile and flexible way in which we've seen the health board work incredibly effectively over the last few months. So I suppose the challenge in this paper is to lay out the way ahead and striking a balance between traditional programme management approach with multiple milestones and reporting, whilst but also a flexible, a responsive and agile approach to delivering this really important work that engages both our staff and our population in a more real-time basis. Going back to Hal's last item, so that we are really listening, learning, and improving in real time. On page 8 of the paper, therefore, we outline 7 proposed work streams that don't work consecutively, but work together to develop this important piece of work. I should say that additionally, this is in the context of the delivering the major trauma network on a regional basis across our emergency medicine footprint in the health board, and also delivering new guidance that seems to be emerging almost on a daily basis from the Royal College of Emergency Medicine, as well as weaving into the work initiatives nationally, such as the Connect Ahead work for emergency departments, which is currently being piloted in Cardiff and Vale. If I may, Chair, the bit I'd like to emphasise is the importance of the partnership panel. Because I feel quite passionate, we've got to do this really well and we've got to do it right. And so often within the NHS, and indeed if you look at healthcare internationally, this is something that organisations pay lip service to rather than do well. And I think that we owe it to our population that we've heard passionately from over the last few months that we involve them in designing and building this service, the safe and sustainable emergency medicine, minor injuries and minor illness service. It's not just about the ED, it's about the whole service. But also what I think the real challenge for us all is to ensure that we don't just design good services, but we design services that are usable and accessible. And then we work together to make sure that we do use them. There's no point having services that are good if actually they aren't used by the local population. And I think we need to develop that joint responsibility, Chair, to do that. And if we can get this partnership panel right, what an incredibly powerful tool that is as the Health Board in the coming months and years develops its clinical strategy and continues to improve the quality of its services. To that end, we will be advertising in the very near future for participation in that partnership panel, and we'll be continually working with partners who've done this elsewhere to make sure that we do it right. I'm happy to take any questions, obviously, Chair, but I said the recommendations in the paper are to note the closure of the previous project, which was framed within the context of the South Wales programme. And I should just observe that the Regional Project Board and the Internal Project Board have both received closure reports in the last few days, even since this paper was written, to follow that process. And now to note the establishment of a new project to indeed deliver that safe, sustainable and accessible emergency medicine, minor injury and minor illness service across the Rhondda Taf Ely locality. Thank you, Chair.
Nick, thank you very much indeed. Maria, come to you first. Maria Thomas.
Yes, thank you for that, Nick. A few questions for me. Can I just ask you how the board will have continuous sight of the project and the development of the project? That's the first question I wanted to ask. So what's your thoughts around that? And could you give us some indication perhaps of some timescales around the project development? And just the third question is around partnership and the involvement of partners. I think you'll agree that you need a specific skill to be able to facilitate this type of partnership arrangement and ongoing discussion, and I was just wondering what your thoughts were around that.
Thank you, Maria. We're obviously very happy to take feedback from the board as to what the board would like in terms of that reporting. In my mind, I suppose, as the risks de-escalate around this area, and as we see this being embedded, we increasingly want to drive this work into normal business within the localities. And also any safety risks, and after all, this project was was framed around safety. That needs to report through quality and safety. So I'm sure the board will be wanting for the next few months at least bi-monthly progress reports. But I think my challenge to us is that we do need to push this back into normal business as soon as we can, escalating concerns and issues as they arise. In terms of the partnership working, I think that is quite complex, isn't it? And we have the partnership panel, and I think for me the partnership panel is primarily about partnership with our local community and ensuring also involvement, of course, of our staff and including our clinical staff. We also need to have that more formal involvement of our partnerships, including local authorities. The Regional Project Board, which included our healthcare partners predominantly, including WAST, the ambulance service, felt that actually we could do that in a less formal way going forward than we had historically, because this really is now Cwm Taf Morgannwg business rather than regional business. So I think those conversations need to continue, and of course we do have enough formal relationships and meetings with partners to enable that to happen. I would hope that it wouldn't be necessary, but clearly if at any stage through development of the service we encounter problems, then we might need to consider how we would do that more formally. In terms of delivery of the project, of course, much of it is actually already happening, and apologies, board, but a lot of this work is already well underway without the board's formal endorsement. But actually, perhaps no apology. That's the way it should be. So I suppose we would hope to see the establishment of the partnership panel, or at least the adverts going out for that within the next few days, and the first meeting of that happening during, I would hope, October, but I suspect it will be an iterative development of the partnership panel. The workforce model and the financial envelope that's needed to support that, we're looking at, I mean, there's already a very good draft in place, but we're looking at that perhaps to be in place by the end of October. The project, that will all be covered in more detail in the project initiation document, because despite my plea for agile governance, there does still need to be that project initiation document with all the time frames will be laid out in that. It would have been somewhat irrespective. I wouldn't. We needed to wait for the board's approval of the project today in order to finalise the detail of that PID. I must confess it is partly written already, though. I hope that gives you a flavour of where we're going, Maria.
Yes,
but also that need to be agile as we do this.
Yes, it does, Nick, and thank you for that. It gives me the assurance that I needed around those points. Thank you. Thank you, Chair.
Thanks, Maria. Sharon, come to you next.
Thank you very much, Chair. So again, my thanks for all of the work that's been going on this particular topic right across the board, Nick and the teams, as well as our communities. I guess what I wanted to underline was one of the issues that Nick was talking about was how we use the new approaches that we've set out as how we want to operate as CTM going forward, alongside the learning from COVID with the flexibility and agility. So utilising and empowering the new operation model, so the integrated locality groups, those people that should be engaging most with the relevant communities and should really understand the local services. And then the way we glue that together in a governance terms across the patch was what we're calling systems groups. And those again are clinically led, and those, if the board recalls, are going to be tasked with outcomes, standards and the planning piece. So that's where we get the glue that goes across CTM. And it's going to be super important, I think, going forward as we learn how the new governance models and the new operating model works together, that we become confident in the work in which those are doing. So the traditional method of something like a PID, a project initiation document, coming all the way up to the board should never happen. Absolutely should never happen. That's something that perhaps the members will want to deep dive into outside a board meeting. So I'm heartened by the questions that Maria has asked in getting some assurance around how that governance process will work. But this is a new way of working, and we've got to secure that ability to retain the agility and the responsiveness, enabling things to work in parallel, and particularly for this service where we're not starting with a blank canvas. You know, this is a service that we're already providing day in and day out. And what we're talking about is something that is improving and changing, not starting de novo. So again, me being in slightly cheeky mode, I would just ask the board to, give further consideration to how we as a board, with our very important supporting committees, do that oversight and scrutiny whilst allowing that new operating model to really deliver with that clinically led, empowered approach that we really want to get in place across the organisation.
Sharon, thank you. Jane, come to you next.
Thank you, Nick, and thank you also, Sharon, for that heartfelt plea. My question is really around the partnership panel. I'm really interested in this. It's a piece of innovation in terms of how we're working. I know it's particularly important in relation to this specific project because it will only, or not a project really, is it? This new way of working, because we will only be successful if communities are involved, if communities are engaged and supportive of what we're trying to do, and actually commit to changing the way they use our services and actually engage with the new ways of delivering services. So I suppose my question is a bit wider. Do you see that this sort of partnership panel approach, which is, I think you said, less formal than our traditional partnership with a big P panels, do you see that this less formal way will be the way we seek to engage communities as we change a variety or develop different approaches to a variety of services? Really interested in that. I suppose it's also part of the question that I asked Kelechi earlier on.
Thank you, Jane. I'm really interested in it as well, because I think there are so many examples where this is done badly, and there are so few examples perhaps where it is done really well. I'm not sure about less formal. I think it does need a formality and a structure to it, but I think it needs to be agile and honest in its approach. Personally, and we are taking advice from experts who've done this well elsewhere, including an organisation called the Consultation Institute. I think if it is purely a group of people who are representatives of the community, it can lose some power. We do need that representation. We need to ensure that we look at equality issues, we look at language issues, we look at geography issues, we need to look at those people who have particular health conditions. But it's also that honesty about a dialogue where we say, you know, okay, this is what as a doctor, look, you know, to me looks like a really good model. And we need to say, how does it look to you as a patient? How does it look to you as a carer? How does it look to you as a community nurse in the upper reaches of the Rhondda Valley? What are the issues that you can spot in it? And how can you help us spread this model and get further feedback? I don't think it is just about engagement, and nor is it the only way of engaging with the community. I'm desperately trying to avoid saying co-design, I suppose, because I think that is a sticker that gets used all over the place and sometimes less appropriately. But I agree. I would prefer to spend a little bit of time getting this right and being honest with ourselves if after a few weeks and months we haven't got it quite right and we need to tweak and change it, so that we can, this is something, a way of working that we can fall back on in the future. So I haven't got a packaged answer yet, Jane. I prefer to spend the time and do this really right, because I think it has the potential to be very powerful.
Okay. Thank you very much. Great,
thank you, Jane. Nick, thank you very much. You'll have heard there the genuine interest, I think, from board members about this new approach that we're pioneering probably in this area, but we would want to be part of our way of doing business in the future as a health board, wouldn't we? That working with our communities rather than what may historically have been the case. So I think we'd be really interested to see how the thinking develops on that and the approach to be taken, because I think we're all expecting big things from that. You've outlined very helpfully the reporting mechanisms. I suppose, Nick, it behoves me just to raise one issue which is slightly, which bedevils all of these things, which is about nomenclature. We've had several conversations with people about, what do we call it? Is it an A&E department? Is it an ED? Is it minor injuries? Or is it, what about minor illnesses? And I don't expect you to come up with a new lexicon off the top of your head, but the names that these things are called are quite important, aren't they?
Thank you, Chair. Indeed they are, and apologies for the somewhat cumbersome but all-encompassing emergency medicine, minor injury and illness service strapline at the moment. And I think, the profession is increasingly moving away from the accident and emergency nomenclature, but we do need to be selling this right, both so it's understood within our organisation, but also by the population we serve. So I'll work on it, Chair, but no easy answer yet.
I think there'll be a lot of people across the health service who'll be interested in what your answer is, Nick, but thank you, that's very helpful. Colleagues, nobody else is indicating that they have any questions, so we're asked to essentially to approve two things: the establishment of a new project as set out in the paper, and the formal closure of the former emergency medicine and inpatient paediatric services project. Both of those are set out in the paper, and I take it from people's responses that we are happy to approve both of those things. Just pausing to see whether anybody has any objections, but I don't see anything coming through. Nick, thank you very much indeed. That's very helpful. We press on. Item 3.3.2, the update on risk management. Callie, you've done us a very helpful paper. Anything in particular that you want to say in addition?
Thank you, Chair. Just a couple of key points, if I may. I just wanted to stress the purpose of the paper is to provide assurance to the board on the progress that we've made over the last couple of months. And the absence of the full risk register at today's meeting is not due to lack of progress. It's really because there's such a robust review ongoing at the moment. The board will receive the full risk register at the forthcoming board development session, and we'll have an opportunity there to review all the risks in detail. It will also help us when we define and review our risk appetite statement. So just wanted to provide assurance that there is significant work underway, and I hope that's illustrated through the paper. The appendices also outline some of the progress in a bit more detail. So I didn't want to add any more unless anyone has any comments for me. Thank you, Chair.
Kelly, thank you very much. I think it was a very clear paper. Nobody's indicating that they have any additional questions other than those which I think people had a chance actually already to ask and which you've answered. So Kelly, thank you very much. We're happy to note the report, and we look forward with anticipation to our discussion in a month or so's time. Thank you. Let's move on then. Item 3.4.1 is a very substantial item with a very substantial set of papers. I was delighted to come across Appendix 4.2.2.5.4 and its friends. But that just really reflects, I think, the complexity of this. Getting the health service back up to anything that resembles adequate capacity is a huge challenge, not just for this health board, but for the entire National Health Service. Claire, thank you very much for the paper, which is very, as I say, very detailed and very helpful. Anything in particular that you want to draw our attention to, Claire Williams?
Thank you, Marcus. Yeah, it is a very detailed document that the board has received, and I suppose I probably don't make any apology for that at this stage. As you've described it, Marcus, already, it is a reflection of the considerable amount of work that has been undertaken through the organisation as a consequence of COVID, and the detail of the plans that we have in place to take us through in the coming months. I know that there will be a discussion that's required around this, and so I don't intend to spend a lot of time introducing the paper. I will just form a few key points and remind members that this is the Q2 return, and it builds on our Q1 approved document that we submitted through to Welsh Government a few months ago. It does comply with the Welsh Government operating framework, which had been submitted to us in June. A key focus of that was around winter planning, in addition to making sure that we were building on our plans. The way that we have been enacting what is within this document and our plan is through a series of executive-led work streams. So our Resetting Cwm Taf Morgannwg programme, which has got 9 work streams, which we have made sure align to the organisation's strategic wellbeing objectives. It's really important that we haven't lost sight of our mission and vision as a health board, and so it has been really welcomed that we are able to frame our resetting agenda against our objectives. I did just want to pick up a couple of key items before I'm sure, Marcus, members will have some questions and my exec colleagues may wish to come in with some further detail. The guidance from Welsh Government really did ask us to focus on essential services, ensuring that we had the right measurement and surveillance processes in place so that should a further COVID peak be coming our way, we were suitably informed. And I'm pleased to say that we've got both of those aspects within our plan. Kelechi, as our Director of Public Health, has already articulated some of that surveillance piece. And we do have robust monitoring, which means that we should at least have 14 days notice of having to make significant changes in the health board by way of response. Movement in terms of essential services has seen those where we had assessed ourselves as not yet being able to deliver them. We had 5 areas when we submitted our Q1 plan. I'm pleased to say that we now have all services in the health board delivering at that essential level. At the time of writing the paper, there was one question around lung cancer services for the residents of Bridgend, but I'm pleased to say that that pathway has been resolved. And as of last week, we are offering that pathway through to Cardiff and Vale Health Board. And so the service is available there. A couple of other key aspects before we get into the discussion. Through the development of the resetting programme, we have actually come up with a fairly comprehensive set of strategic measures, and on page 14 of the resetting document, you will see that against each of our strategic wellbeing objectives, we've now got an agreed set of measures at a high level, outcome focused, which will help us understand if we are making some progress and the right progress against our objectives. We also have, and you've referenced, Marcus, a number of the detailed appendix, but actually it is important that primary care in particular, our mental health services, our optometry, our dental and our community pharmacy services have got their recovery plans in place, and as a board we are assured that they are there, and so that is contained within the plan. I know that we've had a few questions in advance of today's meeting, particularly focused around the capacity that we have in the organisation and understanding the demand from within our services. So I did want to bring in Alan Laurie, perhaps in a moment, to talk through that in a little more detail. It is a fiendishly difficult, to use your language, Marcus, a fiendishly difficult area to articulate in one straightforward answer. And members will note that Welsh Government actually asked for completion of a capacity template by the 24th of July, which they then subsequently withdrew, recognising the complexity of the question that they had asked and how difficult it is to articulate it in even within one spreadsheet. And that's because of the number of pieces of the jigsaw that we are working on at any one time. And so in order to understand the capacity that we have, particularly in secondary care, we've made sure that we've developed standard operating procedures which take account of all of the COVID guidance around safe practices of work, so that we can understand in theatres, in our ward space, what we can deliver, and those are now in use. We've identified the areas within each of our district general hospitals which will be used for non-COVID work. And so for each of our district general hospitals, we've got at least 2 theatres and approximately 24 beds across the piece. We're also obviously using the Nuffield Vale Hospital to supplement that, and we've got plans in place to work more closely with Swansea Bay in Neath Port Talbot coming into play in September to try and increase that capacity. And we've got options being developed to expand that capacity further, both across our district general hospitals and more widely if it's required. That's one half of the jigsaw. The other half of the jigsaw is then the demand and those patients who need to be using that capacity as quickly as we can. And that demand is made up from our unscheduled care demand. It's made up from our COVID, which, whilst low at the moment, we need to recognise that there may be further requirements for COVID capacity, and obviously our non-COVID capacity. That assessment of the demand is underway, and we know that for our unscheduled care, we're up at about 80% of our pre-COVID levels, and we understand our COVID demand, and our non-COVID demand is being clinically assessed, and so that we can understand those urgent categories and our more routine weights, and so that we can make sure that the capacity that we do have available to us is used appropriately, and that we are inviting the correct patients to come in at the correct time. So a whole load of work is underway within the organisation. It's a huge agenda. As I have previously said, what we're doing at the moment is producing an integrated medium-term plan, which is a 3-year plan, but we're trying to develop one of those every quarter at the moment. We can anticipate that that will continue for the remainder of the year. But it is heartening to see, I think, the progress that we have made from Q1 into Q2, and I don't see any reason why we wouldn't continue to make the same level of progress as we move into Q3. So I pause there for questions, and no doubt some of my exec colleagues may wish to come in at certain points.
Thanks very much. Thanks, Claire. You did mention that Alan might want to come in with some sort of further observations on this issue about how far back are we to anything like full capacity, and what expectations can we have for that over the future. Alan, anything you wanted to say about that?
Yeah, Claire stole every single bit of my thunder, I think, there in explaining what the various capacity elements are, and I think she absolutely described it perfectly in relation to the various elements we're dealing with across each of our district general hospitals, community hospitals and beyond. Just probably to put a little bit of it in context, we have worked, I think, at the Health and Sport Committee, you'll recall, we talked about the fact that Q1 was about planning and Q2 was, so Q1 was about intent, and then Q2 was about beginning to get into sort of doing around it. And if you look across the course of the month, at the beginning of June, we were doing something in the order of less than 100 urgent elective surgeries. As of last week, we were nearly at 300. So we are beginning to increase that number fairly substantially, and there is more to go around that. However, that is substantially less than what we would have been doing in a normal week in the pre-COVID period. So the pre-COVID period, the average number of operations, both inpatient and day case, would have been something in the order of about 850, and we're at the 300 level. So the gap is considerable. We've got something like 5,000 Cwm Taf Morgannwg residents on our urgent waiting list at the moment. That doesn't mean they all have to be done within the next week. That is broken down between those that need to be done urgently within the next 72 hours, and they are now being brought in. Those that need to be done within the next 2 to 4 weeks, those need to be done within the next 3 months, and those that need to be done 3 months and beyond. And I think part of the issue that Claire was referring to is we're now automating that system such that we have got very clear very agile view across CTM in relation to where our demands are, and our demands are in that category, and where our capacity is. But you can see, no matter what we do with the capacity, as it stands right now, it would be wrong of me to say anything other than we are continuing to make baby steps into that growth space, and that's the real challenge as we move forward over the next month and into the next month. What more can we do within our facilities to increase that capacity, and where do we get, when we get beyond that, what other options do we have? I have to say, having spoken to my colleague directors of ops in other health boards, all in a very similar place in terms of identifying capacity within their district general hospitals, capacity within potentially private hospitals, and then sort of managing that gap through. This doesn't go anywhere near routines. We have focused on the urgents, and there's another conversation probably to be had at a future point in time around the routines. One of the issues that Claire and I were talking about earlier in the week was that it's difficult to kind of get into the level of fiendish details, again, to use your phrase, Marcus, through a board meeting. I think we probably would wish to offer independent members the opportunity to maybe have a more detailed discussion with some of the numbers around it over the course of the next 4 weeks, so you really are very sighted in relation to what we can do, what the challenge is, and how we move forward in a lot more detail around that, and some of the modelling work that our colleagues have done to overlay the winter planning assumptions with that which we're trying to do in terms of urgent elective work. I'll stop at that point.
Alan, Claire, thank you very much. That's very helpful, and I think the colleagues would very much want to take you up on that offer of not now, but at an appropriate space, looking in a bit more detail of that. And Mel, I think you very timely, you wanted to come in as well. Mel J.
Yes, Marcus. Thank you, Chair. It was just an observation. I mean, on the 21st of July, I chair the Planning, Performance and Finance Committee, and this particular report was subject to some very, very detailed scrutiny at some length. And I just want everyone to be assured, not only were we praiseworthy about the work that's gone on and the commitment that was undertaken in getting to us where we are today, but also that it had the full support of the Performance Planning and Finance Committee and endorsement for presentation at the board today. I just need to say that, and we really were impressed with all the hard work that had gone on. Thank you, Chair.
Mel, thank you very much. That's very helpful, and I noticed a number of colleagues saying that further briefing will be really welcomed on that. It is, isn't it, astonishing when you look at this. In a few days back in March, we stopped a lot of what we do as a health board in almost no time at all because of the pressure of events. We've now faced a period of many months duration. They're gradually getting services back up to something where they need to be, and acutely conscious that in the meantime, the number of patients who are not getting maybe not life-saving care, because that will be provided, but there are the numbers of patients who are suffering pain, disability, inconvenience, if nothing else, grows by the week, and we're acutely conscious of that. And as I can see, I think from these papers, an enormous amount of work is being done by everybody to try to get things back up to an acceptable level just as quickly as we possibly can. So thank you very much, Claire, again to you, and I know this is a team effort, to everybody who's been involved in this. We're particularly asked to approve the Q2 operating framework, which I think is Appendix 2, isn't it, to the papers, and I think we are very content to do that. Thank you very much. We move on. Item 3.4.2. The integrated performance dashboard. This is going to be, I guess, very much reflect some of the discussion we've just had, isn't it? Claire, over to you.
Thank you, Marcus. This report, hopefully members will note the change in format. We've spent a lot of time with the performance team over the last number of weeks and months, looking at aiming to simplify and make the report, both the cover report and the dashboard, significantly more accessible. and also ensuring that it reflects our new CTM operating model and the establishment of the integrated locality groups. I would hope that members welcome this, but equally recognise, if not today, that further comment would genuinely be appreciated, because no doubt we will iterate and develop this as over the coming months. The downside, I suppose, or the positive side of making a report more accessible is actually, and the reason we really wanted to be doing it was that it helps to improve scrutiny, and no doubt Mel will come in, but actually we did have very extensive discussion at Planning, Performance and Finance Committee last week. And I think we can also see through the written questions and answers that have been asked and provided prior to this meeting that it is generating a significant number of and the right questions. I do see that the purpose of this performance report is to provide insight. It needs to ensure that we're not just providing the data, but that we're providing the key messages and guiding the areas where further scrutiny is required. And I hope, colleagues, that you will agree with me that we've improved and we are getting there. I don't, as a consequence of the scrutiny that we've had to date, intend to go through the report in any great detail, but I suppose the take-home messages from it would be that our pre-COVID challenges remain. Those areas that we were aware of are still there. And I would make sure that I would provide the assurance that over the last few months and in terms of prioritising our work programme moving forward, we are very mindful of this and we are picking up those areas as a consequence to ensure that we are looking to resolve those, not leaving them either paused or forgotten as a consequence of COVID. So again, I pause there and may bring in Alan and Nick perhaps in terms of responses to any particular questions people have.
Claire, thank you very much. Personal view, I think this is a very helpful presentation actually, and for the very reasons you said. There's nothing easier than drowning in numbers which mean absolutely nothing. What we rely on in these papers, I think, is an intelligent analysis of that data and an honest and transparent exploration of the issues that the data throws up. And I think this paper is a very good attempt at that. Thank you. Colleagues, I noticed that there aren't questions coming in, apart from Jane. I think you've got a question.
Thank you, Chair. I think this is a really, really good presentation of the data. It's actually now information rather than just data. And so really congratulate you and the team on that, Claire. Just a bit of a question, or ask for a more expanded explanation around the material in the referral to treatment times. And I think this actually also reflects some of the stuff that was in the previous agenda item. And that's the use of health risk factors in prioritising treatments. I can see there is a bit of a description there, but I just think it would be useful for people generally across the board to have that fleshed out a little bit. And the reason for that is that in the last quality and safety meeting, the application of that came as a bit of a surprise to some members. So I just think it would be worth explaining it.
Shall I come in on that?
Oh. Yeah, thank you, Jane. I'll give a quick overview, and then I think. Sorry, thank you for that, Jane. I was going to give a really quick overview, and then I think Nick was going to follow up. I suppose that I would advise colleagues that this revised structure, and you're right, we referenced it briefly in the resetting framework, and it does play through here. The detail of it is that we're taking the learning actually from ophthalmology, and in ophthalmology over the last year, 18 months, there has been an attempt at developing a prioritization framework which doesn't just split into urgents and routines, but actually provides a little bit more subtlety, if you like, in terms of those definitions. And as a consequence, and you will have seen the detail, we are now looking to prioritize in terms of 4 levels of priority. That is a piece of work which is being undertaken and clinically led in the organisation. So clinicians themselves are reviewing waiting lists and applying this urgency requirement against each patient that they're reviewing. But I would assure colleagues, and this is some of the detail that perhaps Nick may wish to come in on, that it isn't only being done by individual clinicians. There is then a review across a specialty, and then a review being undertaken across each of our 3 integrated localities to ensure that we have consistency in the approach with which this prioritisation is being undertaken. And as Alan alluded to in the previous agenda item, at the moment this is being undertaken mostly as a paper exercise. However, we do have the means over the coming probably 3 to 4 weeks to put this into an automated process, so that actually the patient record will be able to reflect that level of prioritisation, and that will ease the flow, if you like, of all of our demand and capacity planning, and ease also that that process of ensuring that we have appropriate modification across each of the ILGs. So I pause there because no doubt Nick will want to follow up with a little more detail.
Thank you, Claire. I'm not sure I really can add to your detailed response, Claire. I think this is an evolution, Jane. I think we started with individual clinicians responding to individual circumstances. That was probably right and inevitable. We then drew on specialist society and college guidance and fed that into pathways. And of course, that for a while there was some conflict and some confusion around guidance not working together, and there's still some of that as we try to balance risk across the organisation. And then now, as Claire is rightly describing, we're now trying to formalise those processes. I think we as a health service don't yet are not fully able to express risk in this context. I think it's a new language, isn't it, that we need to become more sophisticated in doing. So I'm not saying that our processes won't evolve further, because I think they will and they should. I think also we are re-establishing our ethics committee as a health board, poised, ready, should we be faced with some more difficult decisions to make in terms of prioritisation, that we're working with other health boards to ensure that we look at that in a consistent way. So it is for me that balance of individual clinical leadership, because it's the clinicians themselves, not just doctors, but the whole clinical body, who know their patients and know the impact on their patients, with specialist knowledge and advice and best practice, coupled with an all Wales consistency, both from a clinical prioritisation and ethical and an ethical approach, which means it's very difficult.
Thank you. So it's really clearly establishing the clinical need and the clinical priorities. How are we keeping patients informed of where they sit within the priority lists?
Can I come in on that? We're not at the moment, Jane, in any systematic way, because it's not possible to, given where we are with COVID. So I think it's part of the work that all of the teams are doing at the moment. And I think when we had a deeper conversation yesterday, I alluded to the fact that we've got a lot of work to do along with our other health boards across Wales on how we can translate all of this that you've heard about today into something that is absolutely meaningful for individual patients who, you know, the information they will want to know is, when is my appointment coming through? So you've heard from Alan where we've got to with understanding where we are with building the capacity, from Claire and Nick how we're trying to determine the urgency and bring patients in. We haven't started to get into grips with the routines, and then how we get into talking with individual patients is just an enormous challenge, and we're nowhere near that. So I think we've just got to be upfront that where we are with respect to trying to come out and reset after the COVID, and we're still in the middle of COVID, that's just a step too far for us at the moment. But we completely recognise that that's where our communities, that's where our patients would like us to be, but we're not there yet.
That's really helpful, thank you.
Jane, thanks very much. Mel, I think you wanted to come in next.
Yeah, thank you, Chair. Thank you, Claire, for this report. As you know, this is the second time I'm seeing this report because it was subject of a detailed scrutiny last week at the Planning, Performance and Finance Committee. And I'd just like to bring context here without just touching on one specific, because I think, you know, there's a lot of detail in this report and a lot of performance, but I think there's also some brilliant stuff. And I just look at indicator 46, for example, which is on page 13, and anybody reading that and putting it into context of what we've been going through with COVID-19 and all the pressures that we've been having in our midwifery and patient care, isn't it really heartening to see? And I know we felt this as a committee last week, that we've seen a reduction in concern and complaints over the last 3 months, significant reduction, whilst alongside that we've seen an increase in compliments that we're receiving for the care that we're providing to the families and the patients that we're treating, which is really obviously an indictment of how excellent the staff have been performing and committing themselves to this work. And if we just read further on about the Ombudsman's annual letter, which indicates that we're one of the best in relation to referrals to the Ombudsman in relation to malpractice and bad behaviour, I just think it's quite heartening and needs to be recognised. So this is why not only did we note the report, but we commended the report to the board, and we also commented on the style and the structure of the report as well, Chair. So I thought I'd just make those points known on behalf of the committee in my capacity as Chair. Thank you.
Thanks very much, Mel. That's very helpful. Sharon?
Yes, thank you, Chair. So some of the points that people have been making, I just wanted to underscore the work that's been going on with the teams, the development work that's been happening with the teams under the leadership of Claire, Nick and Alan in particular, but particularly with Claire and some of the information work. So we've been trying very hard to mirror the approach that we want, which is something that is informative. And I think Jane mentioned turning data into information, something that is clinically led and measures that are meaningful to the clinicians carrying out the day-to-day work. So how we do that in a way that is actively useful up and down the system, and then how we present that information back into the system at all levels, whether that be at the integrated locality groups, for individual directorates and clinicians on the ground, or whether it be into an assurance committee or at board level. And I'm hoping that you're beginning to see that the way the reports are presented, they're beginning to get that thread going through them. Claire and the team have also worked very hard to make sure that we're getting a really strong thread going between our overarching strategic mission and vision statements, our objectives, and then the work streams that are coming through. So things are really starting to link up to that whole system CTM approach. Now we've got a long way to go yet, and I think Claire would be the first one to say it's not a done, you know, it's not a finished piece of work, but that's what that's what we're aiming at here, to get something that makes more and more sense, that can be understood more and more easily, and that will mean more and more questions, I suspect, as well, but something that is genuinely being then used to enable the decision making at the clinical coalface, as well as being able to give assurance through the system. So I just thought that was important to say, Chair, particularly given some of the excellent questions that have come through from members that I think are starting to underline that.
Sharon, thanks very much indeed. And this is a crucial document, isn't it? And will be particularly important as we go forward, as almost as in some of these indicators, a slight sense of unreality at the moment, isn't there? Because some of them reflect a period of time that is so abnormal that it's difficult to interpret some of the figures. But as we move out of this period, they'll become increasingly powerful and potent, I think, as indicators of how well we're doing. But you've heard there, Claire, compliments really from colleagues. Thank you to you and the team for an excellent presentation, and the test will be how we use it in the coming months. Thank you very much. And then let's move on, colleagues, if we may, to item 3.4.3, which is the finance report. And I'll hand over without any further ado, Steve, to you. Steve.
Okay, thanks, Chair. I'll just draw out just 2 or 3 key points. I think the first one is that our costs for month 3 were lower than we anticipated by around 3-4 million. That was largely as a consequence of what we've been discussing in terms of lower than normal planned care activity. So some of this hasn't been fully reflected to date, including those costs of our patients at other health boards, particularly Cardiff and Belinda for cancer treatments and so forth. So some of those lower costs are starting to come in and have been reflected in our reporting, together with a little bit of slippage on some of our setup costs like TTP and so forth. So lower than projected costs in month 3 for those reasons. At the same time, we've had first tranche of Welsh Government funding for COVID, 10.3 million. So those 2 factors, lower than projected costs over the first quarter, about 14.7 million compared to our forecast of over 18, together with that first tranche of Welsh Government funding and a relatively low overspend that's not attributed to COVID, is giving us a net deficit for the first quarter of 4.8. So those are the key points in terms of the year-to-date position. In terms of the forecast, our latest forecast, as per the report, before Welsh Government funding for the year as a whole is 66 million. So that is lower than is reflected in the Q2 plan that we've been discussing. And that's largely, again, because of those lower costs of drugs and other treatments from lower than planned elective care. And that will abate over time, but that does reduce the forecast. I think the key things going forward are trying to continue to respond to COVID in an effective way, but in a value for money way as possible, and also continuing to engage with Welsh Government on funding. I think Kelechi mentioned that we've approached Welsh Government for TTP funding. We've also done the same on the costs of the Vale, which the board has approved, but also more generally. And there've been some independent member questions on this, but it will only be gradually through the year that we become clear on what the full Welsh Government funding is. So I think those are the key points. That's our key risk really, is around Welsh Government funding, but we are on the case with that and engaging with them closely. So I'll pause there for any further questions or comments, Chair.
Steve, thank you very much. The level of uncertainty in this situation is, I guess, almost without parallel. Is it? Have you in your professional career, can you remember a situation where there were so many bits that were unknown?
Nothing remotely of this scale. I've never reported a deficit of this sort of level either, but the level of uncertainty is obviously huge, and I guess one of our challenges there is, goes back to the previous discussion on planning, is to align, make sure our financial forecasting is aligned with our service plans as we get more granularity on those plans.
Thank you very much. Colleagues who've taken the opportunity to ask several quite detailed questions, which Steve you've responded to before the meeting, and those will go into the minutes. So that's again, I think, really helpful and enables people to probe into some of the detail. Phil White.
Thank you, Chair. Only a quick one. Thanks, Steve, and just the good news that we've had some of that money's in. I'm just asking, looking at month 3 forecast, quarter 3 forecast in comparison to 1 and 2. It seems, I don't know. To me, is it a forecast that's lower in anticipation? With what possibly could be a second wave and what possibly could be some difficulties in our winter planning pressures, or are you comfortable with that forecast for quarter 3?
I mean, it's lower.
Sorry, month three forecast. Sorry, Steve.
Yeah, no, sure. So the reason predominantly, and there's a sort of detailed explanation in the report of the various ups and downs, but the key reason it's lower than we forecasted in our Q2 plan that we've been discussing is because of those greater underspends, if you like, from lower than normal elective care. So that's the reason that's lower. One of the major uncertainties is exactly what will be the step up in capacity required for both the normal winter and for any second peak. We have got some provision in the forecast for that, but that is one of the really major areas of uncertainty. And I guess we will never know, so we will be able to develop more accurate plans and contingency plans, but they will be contingency plans because we don't know the scale of that, but we have made some allowance for that in the forecast.
Thank you, Steve.
Thanks, Phil. That's great. I think then, Steve, those are the questions that people had. We note all of the uncertainty and the caveats around this. It's a very, very difficult time, isn't it? But as always, we're putting the health needs of our population first and doing what they require, and then making sure that we address the financial consequences in the most professional way possible. So thank you very much, Steve. That's very helpful. Colleagues, we move on then on the agenda. We've got a couple of items for information. So 4.1 and 4.2, the Shared Services Partnerships Committee Assurance Report from May and the EASC report from July. Anybody want to raise any issues in relation to those? They're only here for information. I think we're content with those. So we finally come to any other business. I'm not aware of any. Nobody's raised anything with me, so I'm taking it that there is no other urgent business. Very conscious today that because of technical issues, 2 of our independent members have been trying assiduously to get in, but it simply hasn't been possible, Kieran and Paul. So we really need to sort out those technical issues before we have our next meeting, and we'll do all we can to do that. But those colleagues who were able to join, thank you very much. I think we've had a good discussion, not just under the circumstances, but a good discussion. So thank you all very much indeed. And board members, I remind you, we have another meeting at 1:15. Thank you very much.